Now, pirfenidone is best known as an anti-fibrotic and anti-inflammatory drug used systemically for idiopathic pulmonary fibrosis, and mechanistically, it dampens the signaling from transforming growth factor beta-1, also known as TGF-beta1, while also reducing several inflammatory mediators in different models. So why might this matter for androgenetic alopecia? Because in androgenetic alopecia literature, inflammation and fibrosis are part of the condition and its progressive nature. All in all, the takeaway message here is this: try to reduce any sort of inflammatory issues you might have on your scalp, especially ones that might end in fibrosis. Hello everyone, and welcome back to yet another video. So one thing that's common to many alopecia variations, whether it's androgenetic alopecia being male or female pattern hair loss, or even the scarring alopecia variations like lichen planopilaris or frontal fibrosing alopecia, is the way inflammation shows up and quietly destabilizes the scalp environment. And even outside of hair loss, there are many skin conditions that can generate inflammatory noise, so that if it does happen on your scalp, well, it just makes the environment less stable over time. Now, as somebody, speaking about myself that is, who's been treating androgenetic alopecia for about 5 years now, I've dealt with some inflammatory issues along the way. I had chronic seborrheic dermatitis, eczema, and even a bout of folliculitis. After using 200 mg of doxycycline daily, 10% benzoyl peroxide shampoo daily, and 1% cycloperox shampoo alongside with 0.05% clobetasol propionate shampoo daily for about 2 to 3 months, my folliculitis then subsided along with some of the seborrheic dermatitis issues that I had before. I then shifted into a maintenance protocol. Instead of using clobetasol propionate shampoo, I switched to using 0.05% clobetasol propionate solution and 0.005% calcitriol solution, morning and night respectively, about 1 to 3 times a week. Long-term topical steroid use runs the risk of skin atrophy, so I use calcitriol as a means to prevent this alongside with the potential of combating inflammation from other aspects via the vitamin D receptor. There are some studies that show using calcitriol alongside with a corticosteroid can prevent that skin atrophy. So really, I see it as the best of both worlds, because calcitriol is also anti-inflammatory. So you can think of these two compounds as really just tag teaming and taking on any sort of inflammatory issues you might have. I've also been using medium chain triglyceride oil, also known as MCT oil, mostly made up of caprylic acid being the C8 variation, capric acid being C10. And I usually try to avoid using anything that has C12 being the lauric acid, because that type of MCT tends to feed Malassezia, and that is the fungus that drives seborrheic dermatitis. So by using C8, C10 being caprylic acid and capric acid, you're going to actually prevent and restrict the Malassezia overgrowth. And a lot of people do not realize this, but androgenetic alopecia can come with different scalp sebum, oil, and microbiome profiles that change over time, and this will cause for the overgrowth of certain microbial populations. And there's a Japanese paper that documented this titled, quote, "Scalp Microbiome and Sebum Composition in Japanese Male Individuals with and Without Androgenetic Alopecia," unquote, by Suzuki and colleagues. The authors uncovered that men with androgenetic alopecia had higher sebum triglycerides and higher palmitic acid, and they also had higher abundances of Malassezia restricta on the scalp, plus a bacterial shift with higher Cutibacterium and lower Corynebacterium. Now, the interesting thing about Cutibacterium is that it is one of the bacteria that contributes to acne and even folliculitis. There's actually an interesting paper on this topic that I won't fully get into, but the paper's titled, quote, "Do Cutibacterium acnes and Staphylococcus aureus define two different types of folliculitis?" unquote, by C. Fernard and colleagues, 2018. The authors conclude that Cutibacterium acnes may be involved in the pathophysiology of scalp folliculitis. They also suggest that there may be two broad types of Cutibacterium: The first being Cutibacterium acnes folliculitis and non-Cutibacterium acnes folliculitis. They also propose two ways in which scarring versus non-scarring folliculitis may occur, and how Cutibacterium namnatense, which is a specific subspecies of Cutibacterium, contributes to a rare folliculitis variant called quinquad folliculitis decalvans. Now, again, this is a part of a broader folliculitis family, and this includes a simple folliculitis where really it's just superficial, so on the surface layer of the skin, it's not in any deeper strata of tissue. So here you just see like small pimples and bumps underneath the hair follicle, here and there, nothing too severe. And then you have acne cheilitis nuanceae, and that's pretty serious. People usually get that when they use like barber equipment that hasn't properly been sanitized. And then finally, again, what I mentioned before, the quinquad folliculitis decalvans, that's that very severe, inflamed, tuft hair follicles where you really just have this bacterial issue that's running amok on the scalp. And in this case, it's more likely to cause permanent hair loss due to scarring alopecia. But yeah, for folliculitis decalvans and even superficial simple folliculitis, those seem to be related to Cutibacterium. So the reason that motivated me to use MCT oil in my stack is because medium-chain triglycerides, at least some of them, have an antimicrobial activity to it. When we're looking at bacteria specifically, Cutibacterium, we actually have a study from Japan we can reference here, titled, quote, Development of Skin Sebum Medium and Inhibition of Lipase Activity in Cutibacterium acnes by Oleic Acid, unquote, by Nakase and colleagues, 2022. By shutting down the bacterium's lipase activity, the bacterium will find it harder to transform other skin oils and triglycerides into free fatty acids which it would feed off of and further drive irritation and inflammation. So in this case, oleic acid or capric acid being C10 or caprylic acid being C8 would pretty much reduce the food supply that the Cutibacterium would use, and thus, as those bacterium populations die out, you would have less inflammation under the skin, and that would mean less acne and potentially folliculitis. But we can look at the same thing when it comes to the Malassezia species. Malassezia is a lipid-dependent fungus and has to pull in fatty acids from the outside world. Now, we have an old lab paper from like 1999 where medium-chain triglycerides and medium-chain free fatty acids, some of them were noted to be toxic to Malassezia species. This is one of the more direct reasons why I take MCT oil seriously in this context. It's not going to be a hair growth stimulant, but it might reduce inflammation caused by microbes. So going back to that paper, they talk about how mechanistically, when lipases on the skin break down these triglycerides, the freed medium-chain fatty acids can insert into the fungal membranes and disrupt their structure and function. The 1999 review summarizing this Malassezia data notes that the exposure to caprylic acid was associated with obvious cellular disorganization in Malassezia furfur, which is again a subspecies of Malassezia. So we're actually causing direct cell stress rather than simply starving out the organism. And there is another practical angle here. Malassezia tends to grow on lipid substrates with longer fatty chain lengths, with growth observed in the presence of certain free acids and related compounds when the chain length is above 12 carbons. So C8 and C10, they're good for the most part, but oleic acid from the other study that we looked at from Japan, that was pretty effective at reducing the lipase activity from the Cutibacterium, and oleic acid actually feeds the Malassezia and makes it overgrow. In fact, in some Malassezia species, it's actually a metabolite, if you will, of its presence. And oleic acid in that particular context has a carbon chain of 18. So that's why I just ended up using the caprylic acid C8 and the capric acid C10. Just very simple to just use those two. But with all that in mind, the MCT oil is a way to push the scalp environment in the opposite direction from what Suzuki's paper, the one we looked at, is describing, where men with androgenetic alopecia start to get this scalp that's high in specific microbiomes, being Cutibacteria and Malassezia restricta. But anyway, I can say that the combination of 0.05% clobetasol propionate solution along with 0.005% of calcitriol did a real good job at calming things down on my scalp inflammation-wise. But we're not always satisfied, right? So I figured that there might be some areas on the scalp I may be able to improve. And this led me to look at my biopsy report. Now, earlier, before I got into the rambling, I mentioned that I had folliculitis. And that was due to various issues that I had about 2 years ago. 3 years ago now, maybe. So when I got the biopsy, it was noted that I had minor fibrosis in the area. And I thought that I may be able to recover some ground and potentially reverse layers of fibrosis that might be concealing and or restricting some follicular growth. Furthermore, I might be able to get rid of the early fibrotic signs that come naturally with androgenetic alopecia. So I decided to do something a bit more obscure: pirfenidone gel. Now, pirfenidone is best known as an anti-fibrotic and anti-inflammatory drug used systemically for idiopathic pulmonary fibrosis, and mechanistically, it dampens the signaling from transforming growth factor beta-1, also known as TGF-beta1, while also reducing several inflammatory mediators in different models. So why might this matter for androgenetic alopecia? Because in androgenetic alopecia literature, inflammation and fibrosis are part of the condition and its progressive nature. Okay, so you stop DHT, right? All right, sure, that's fine. But DHT in some cases has already caused some downstream inflammation issues that you'll be wise to solve if it's causing an issue for you, if it's severe enough for you. Histological studies show that follicular microinflammation often appears early, and over time, you can see thickening of the peri-follicular sheath and increased collagen deposition, leading to peri-follicular fibrosis in more advanced cases. And this is why they say end-stage androgenetic alopecia involves a superficial fibrosis on the scalp. If you think about fibrotic tissue, it's usually shiny, right? And just think about how shiny the scalps of bald men are. That shiny layer of skin you see, some of that is fibrosis. And it's very, very hard to reverse full-on fibrotic tissue. But you can possibly make that tissue better by using an anti-fibrotic sort of topical. And this is where the mechanistic overlap gets interesting. Dihydrotestosterone, or DHT, signaling the androgen receptor, can increase TGF-beta1 and type 1 pro-collagen expression in the scalp dermal fibroblasts. In one mechanistic study by Yu et al. 2006, it suggests that androgen-induced TGF-beta1 and pro-collagen may contribute to peri-follicular fibrosis in androgenetic alopecia. So we can see how pirfenidone here might help in this case. Separately, Shin et al. Showed that androgen-induced TGF-beta1 regulation in hair follicle dermal papilla cells is mediated by reactive oxygen species, in that this effect can be prevented by antioxidants, again pointing to a real biochemical bridge between androgen signaling and pro-fibrotic signals. So let's put this simply. Downstream of DHT and the androgen receptor signaling, you can plausibly get a local environment with elevated TGF-beta and pro-cytokines like interleukin-6 or pro-interleukin-6, and over a long enough time frame, that micro-inflammatory pressure can push follicles toward miniaturization and more fibrotic microenvironments. Now, let me be clear here and say this. I'm not saying that TGF-beta is causing androgenetic alopecia, but it is a factor that comes after DHT interacts with your hair follicles. So yeah, take your 5-alpha reductase inhibitors, whether topically or orally, but it is increasingly hard to pretend that TGF-beta1 is irrelevant. And if there's a way to address it, why not? But there's a key point here. We do not have strong clinical trials that show pirfenidone regrows scalp hair in androgenetic alopecia. Just to be clear, right? I'm not presenting pirfenidone gel as a sort of hair growth treatment for androgenetic alopecia. So I'm not presenting this as a proven hair loss treatment. Rather, I'm presenting it as biologically coherent and aimed at the inflammatory and fibrotic aspects of the condition. But what we do have are real human studies that show that topical pirfenidone can meaningfully reduce fibrosis in many skin conditions. For instance, the study by Armand Ariz, Borunda et al. used 8% pirfenidone gel 3 times daily and found that it was more effective and safe than standard pressure therapy for hypertrophic burn scars for pediatric patients. Another paper by Rodriguez, Castellanos et al. Reported clinical and histologic improvements using 8% pirfenidone gel in localized scleroderma. And this is a chronic autoimmune disease that causes for excess collagen production, leading to the hardening and thickening of the skin, blood vessels, and other sort of internal organs. So that's not good at all, obviously. And certainly that can turn fibrotic over time. So if pirfenidone is actually meaningfully ameliorating a condition like that, that shows how it can potentially be used for scalp conditions. Mind you, in that study, it did so with good tolerability. And there's also evidence that topical pirfenidone can improve healing in chronic diabetic foot ulcers, which again reinforces that this drug can modulate wound healing and the fibrosis axis in real tissue. So my logic is pretty much this, right? If transforming growth factor beta 1 or TGF beta 1 is one of the pro-fibrotic signals that can be amplified in androgenetic alopecia-prone tissue, and if peri-follicular fibrosis really does contribute to that end-stage shell that constricts follicles, then targeting that axis carefully might be a reasonable supportive strategy. So, is there any evidence in the literature that shows TGF beta 1 inhibition actually leads to some improvement in hair quality in people that have androgenetic alopecia? There actually is, and I want to briefly mention botulinum toxin, or as many people know it as, Botox. You'll sometimes hear people cite Botox as proof that scalp tension is the big driver of androgenetic alopecia. Now, I'm not going to go down the rabbit hole in this video. I think I did before, so I'll probably put that in the description below. But there is a separate discussion about Botox and inflammatory or fibrotic signaling in the scalp. Now, we have a systematic review from Ramadan S. Hassin et al. 2023 titled, quote, Botulinum Toxin A for Hair Loss Treatment, a systematic review of efficacy, safety, and future directions, unquote. This systematic review is providing us with a positive signal in the literature that points to the direction of Botox. Because it reduces TGF beta 1 in androgenetic alopecia tissue, it causes for there to be improvement in hair. Because DHT elevates TGF beta 1. So when you sit there and you rationally think about it, right, at least for me, right, go talk to your doctor, you don't have to listen to me. But when I sit there and think about it, I'm thinking, okay, let me do something now to address TGF beta 1. And if that's something that I'm doing also addresses other sort of inflammatory, I guess you can say, markers like the interleukins or even interferon gamma or alpha, whatever it may be, then why not just address it, right? Why not reduce the inflammatory environment on my scalp? And again, if you have inflammatory issues, by the way, right? If you're having itchy, red areas on your scalp, that is a sign that you have inflammatory issues. One thing I like about the systematic review of Botox use and androgenetic alopecia hair improvement is that you can see some studies, there's a substantial improvement, or at least a meaningful improvement in hair count, right? So for the first one, I think it's Freund et al. 2010, it says 18% increase in hair density, 75% overall response rate. So that's pretty cool. And you have another study over here from Singh et al. 2017, and it shows 80% excellent photographic response and a 70% good to excellent self-assessment response. Study number 3 that looks at androgenetic alopecia in this particular review is by Zhang et al. 2019, and it is a prospective cohort study. Over here, 44% had more than 10% hair count changes, and the response rate for the study was 79.1%. Study number 4 from Schoen et al. 2020, again, a prospective cohort study. And over here, a 5.1% increase in hair per square centimeter. Now, the highest rated piece of evidence in this systemic review when it comes to the androgenetic alopecia improvement with Botox is the Zhao et al. 2020 paper. This paper is pretty interesting because it showed 2 groups. We have one group that solely used the Botox injection, and then another group that got Botox injections and oral finasteride. The outcome of the study showed that the group that had the Botox injections and the finasteride had more hair counts than the group that only had Botox injections. In fact, the effective rates for the Botox injection group was 73.3%, and for the Botox finasteride group was 84.8%, respectively. In particularly, if we look at the Zhao et al. Study, it showed that the Botox group did not differ statistically from the Botox plus finasteride group, but in both groups they had a significant increase in hair density. So that's pretty cool. It was a small study involving 63 men, but it was randomized. So that kind of lends credence to potentially TGF inhibition being maybe a short-term sort of benefit. We don't have any long-term studies, but maybe it can be a short-term benefit when it comes to slowing down androgenetic alopecia. And the interesting aspect about this study is that they only did injections, about 4 courses of 100 units of Botox every 3 months for 12 months, right? And using pirfenidone gel, I mean, you could in theory do it daily. I don't do it daily, but you could do it a bit more frequently than you would do an injection into your scalp. So maybe, for me, 3 times a week is more than enough. We also have another study from Tien et al. That involved 37 male patients aged 20 to 51 that were treated with 5% minoxidil topically and 1 milligram finasteride orally. Within the same patients, they essentially split the scalp and they applied Botox to one side and they didn't apply Botox to the other side. And the side that received the Botox had a greater increase of hair density. This is pretty good as a design because you're comparing the subject with itself, essentially. You're comparing one side of the scalp that received what is pretty much the TGF-beta inhibition treatment to another side that didn't get it, and the subject is still using the finasteride and the minoxidil. So any sort of increase in hair count may be attributed to the intervention of the Botox, especially when that improvement is not uniformed and specifically localized to the area of injection. And there are so many studies that seem to show that Botox can help increase hair growth in androgenetic alopecia, and it has nothing to do with scalp tension per se. Nothing to do with that at all, rather. It has to do with the decrease of TGF-beta1, right? So I'm using Botox as a proxy, a mechanistic proxy of what happens when you reduce TGF-beta1, and in this case, that would be the pirfenidone gel. So what this is potentially pointing at is if you are to use Botox with a 5-alpha reductase inhibitor, or rather, let me just say this, if you are to potentially use a TGF-beta inhibitor along with 5-alpha reductase, then you might have some improvement in hair quality. So this is a good paper that points at the mechanism of action of what can occur, what may occur, rather, if you inhibit TGF-beta1 along with other inflammatory signals and you use something that lowers and blocks DHT. It would probably lead to better hair growth. Going back to the systematic review, it also points to something pretty interesting. It notes that Botox has had some sort of improvement in conditions outside of androgenetic alopecia, which leads me to point at, well, if it has TGF-beta1 being, let's say, overactive, right? Whether it's from androgenetic alopecia or from folliculitis decalvans or seborrheic dermatitis or whatever, you might get some sort of improvement, but to be fair, it doesn't look like for folliculitis decalvans that improvement is too crazy with Botox. But who knows? It might be crazy with pirfenidone. It might be a good improvement. So what I'm trying to do here is use Botox as a proxy for pirfenidone, because Botox inhibits TGF-beta1, pirfenidone inhibits TGF-beta1, along with interleukins, interferon gamma, and other sort of inflammatory markers. So the takeaway really is that when you reduce TGF-beta1, you can potentially get increased hair growth, improved scalp conditions, and that's what led me to use pirfenidone gel for the past, I want to say 5 months. And I'm going to make an update video about what's been going on with my hair. I know, it's been like 2 years since I've made a meaningful update, but I've been slowly documenting things, and I have to sit down with my editor to kind of, get the full timeline out. But I'll put 2 pictures over here, right? And this is like after using pirfenidone gel. improved the area for me, at least when it comes to the texture and feel. I felt like there was more like hairs springing out in the area. It felt less smooth and much more prickly over time. And then eventually that area seemingly just grew back a bit more, density. So I thought that was pretty profound. And, that could be due to various things, but I attribute that to the pirfenidone gel use. So I've been using 2 brands of pirfenidone. One is a brand called Ketocell from Mexico. I ordered it from Amazon. I'll put the link in the description. But it's 10 grams, and I paid like $80 plus, I think it was like $40 in shipping. So that was a lot of money for something that, you're not getting much of, to be honest with you. And then I checked out the guys from Daily OTC. Really cool guys. I'm going to start working with them soon. But yeah, they had a particular brand called Perfiska, and that's around, I think, 20 grams, and it's around $35. I've been using them. Now, the shipping from them is pretty expensive. I think it's around $30. I'm in the United States, and that's how much I paid. But still, it's more for what you would get with the Ketocell, so I ended up just buying 2 20-gram tubes from Daily OTC rather than just getting the $80 Ketocell brand, which is around 10 grams that you're getting in total. So yeah, more bang for my buck from Daily OTC. But what about side effects? From topical studies, the main issues look like mild local irritation and maybe some slight burning, but that might be attributed to the formulation that some brands might use. A recent review of skin and scarring application notes that irritation is usually mild with pirfenidone gel and localized. And also it flags a potential phototoxicity risk because pirfenidone can absorb more UV radiation. So if you're using this on exposed skin, please have some sort of sunscreen or maybe, UPF clothing that you can cover with that area. Or you probably just use it at night and you don't use it in the morning. And obviously, you shouldn't take this orally, and you should be talking to a doctor if you're going to use this topically or orally by any means. Finally, another random update that I want to give about my treatment journey. I've been considering a sort of possible update to the stack where, I'm going to use topical sodium valproate. I want to kind of experiment with that. And the reason this is even on my radar is because valproic acid can inhibit a protein known as GSK3 beta. And GSK3 beta, a very important protein called the β-catenin protein, which is important for the Wnt β-catenin pathway. This pathway is inhibited due to DHT. When DHT interacts with the androgen receptor, it activates a bunch of genes that increases the presence of GSK3 beta, and GSK3 beta suppresses beta-catenin, and if that happens, then the Wnt pathway that actually helps the hair follicle grow hair, it becomes more suppressed over time. Eventually, you barely get any Wnt activity, and the hair follicle dies. Or rather, it goes into quiescence, which is dormancy. So for me, I want to see if I can, maybe it's hair greed. You can probably call it hair greed, if I'm going to be honest with you. But I was convinced when I saw the Zhou et al. Korean study, where they ran a randomized placebo-controlled clinical trial in men using 8.3% sodium valproate versus placebo for 24 weeks, and it reported an increase in hair count, suggesting that it may have a role as a potential growth-supporting adjunct treatment. So I'm going to be contacting my dermatologist to get that compounded at a compounding pharmacy. But yeah, all in all, the takeaway message here is this. Try to reduce any sort of inflammatory issues you might have on your scalp, especially ones that might end in fibrosis. After looking at my biopsy report from years ago and realizing that, oh shit, I do have some fibrosis, whether it's from the folliculitis bout that I was dealing with, or if it's from androgenetic alopecia, it is there, right? And it probably messed with some local hair follicles where the inflammation was occurring. So that's why I'm going to be phasing out or just completely stopping my clobetasol propionate use along with the calcitriol, and I'm going to continue using my pirfenidone gel about 3 times to 4 times a week. I only use it at night, and in the morning, I don't use it in the morning because again, it can cause some UV sensitivity. So please, please, please talk to your dermatologist and doctor before you add any new topical treatments or whatever to your stack. But I will be leaving a link to the KetoCell brand that I've used. Again, it's pretty costly, but it does, help. But also, now that I'm using Profisca, I will leave a link to that too as well on Daily OTC. It'll be in the description. You guys can go check it out and see if it works for you, right? Please go talk to your doctor. And again, thanks for watching this video. It's been long, but hopefully it's informative. I'll try to cut it up into different pieces. Anyway, thanks for watching, and I'll see you in the next one. Peace out.